So we gather here today to honor a legacy of a remarkable individual, Dr. Aaron Vinik, whose contributions to the field of medicine were truly transformative. We are privileged to present the annual lectureship in his memory today. Affectionately known as Arthur, Dr. Vinik was not only a prominent figure here at EVMS, but also on the national and international stage. His pioneering work in diabetic neuropathy and autonomic neuropathy sets new standards in the field, shaping the future of medical research. His groundbreaking research on islet regeneration and the discovery of the pancreatic protein in GAP defied conventional wisdom and brought international acclaim to EVMS. Dr. Vinik's expertise extended to the realm of neuroendocrine tumor biology, leading to significant clinical studies and advancements that have had a profound impact on patient care. Beyond his exceptional research, he was a respected clinician, an acclaimed author of numerous publications, and a mentor to countless students and fellows, both local and international. His dedication to advancing medical knowledge earned him numerous accolades, including Virginia's Outstanding Scientist Award and the Lifetime Achievement Award. Dr. Vinik's legacy lives on here at EVMS through this lectureship and the Aaron Vinik Endowed Professorship currently held by Dr. David Lieb. Today, we remember a brilliant mind, an exceptional mentor, and the compassionate healer whose impact will continue to shape the future of medicine. Dr. Vinik is survived by his wife, Etta, and three sons, Howard, Brian, and Stephen. So Brian is here. They are joining us here in audience today. I will now invite Dr. Ilyas Siraj to introduce today's esteemed speaker, Dr. Sethu Reddy.
Thank you, Rehan. It's with great personal pleasure and pride that I introduce to you today's speaker, who happens to be a friend, but more importantly, has been a teacher and mentor for me for almost 3 decades. So Dr. Sethu Reddy is currently Professor of Medicine and Senior Associate Dean for Research at Central Michigan University College of Medicine in Mount Pleasant, Michigan. Dr. Reddy is a son of immigrants from India and grew up in Newfoundland, Canada. He did his undergrad as well as postgraduate medical training at Newfoundland. And then he started residency also in Newfoundland and then went to Toronto at the University of Toronto. He finally joined Endocrine Fellowship at the University of Toronto. And he went to Joslin to do research fellowship under the famous Ron Kahn. And later, maybe a decade and a half later, he did his MBA in Cleveland as well. In terms of his career, I will just highlight 3 things. One is the Cleveland Clinic, where he came in as a fellowship director and went on to become division chiefs over the years. And then he went to Merck, where he became vice president for US Medical Affairs. And he was a leading figure for the success of Januvia when it came out. And then he joined again his alma mater, Joslin, as a director of adult diabetes. And in terms of his career in national organizations, he has been an active member and leader at ACE. And he was actually president of ACE a couple of years ago. And he received the mastership of the American College of Endocrinology for his role for the society. Dr. Reddy belongs to the few triple threat people that are in academia, a great clinician, a great educator, internationally renowned speaker, and also researcher with many grants over the years, greater than 200 papers and abstracts as well. As I mentioned earlier, he had a significant mentorship and influence on me. He was the program director. He recruited me for the fellowship at the Cleveland Clinic, and then he kept me as a faculty. And an interesting thing was actually, both of us left Cleveland Clinic the same day for different reasons, unrelated to each other. And I left for Temple, and he left for Merck as well. Just kind of an interesting, coincidence. And we also worked together at the board review, Cleveland Clinic, and at ACE. They also know each other with Dr. Vinik in the 1980s. And actually, I knew Dr. Vinik for the first time when I was a fellow at the Cleveland Clinic, thanks to Dr. Reddy inviting him to give us a lecture on INGAP. They have collaborated with each other over the years. All in all, Dr. Reddy is an outstanding clinician, educator, researcher, and leader, and also a great speaker, and I might say entertainer as well, sometimes. And so I think he's a fitting person, obviously, to give the lecture today for the memory of Arthur Vinik. So that said, before we do that, there's a couple of things we'd like to do. One is, Dr. Qayyum, you can join me. We have a plaque. I don't know what the camera is for Dr. Reddy. Where's the camera? Okay, we'll show that here. And so it reads, presented by Diabetes Center, Internal Medicine, at the second Aaron Vinik Memorial Lectureship in Diabetes and Endocrinology for the distinguished speaker, Sethu Reddy, Professor of Medicine, Senior Associate Dean at Central Michigan University. He will be presenting on the origins and future of incretin-based therapy, May 28, 2025. So we'll send it to you with receipt and signature required.
Thank you.
So that said, I'm going to invite the Viniks to come and join us for a picture here with the background, and then we'll go. Dr. Lieb as well.
Dr. Reddy, you can bring your slides up whenever you're ready.
Okay.
Dr. Reddy, you can go ahead.
Are you able to see the slides now?
Yes, sir.
Okay, great.
Yes, yeah.
There we go. Well, good afternoon, everyone. Thank you, Dr. Siraj, Dr. Qayyum, for the wonderful introduction, and again, reiterating the greatness of Dr. Vinik and his leadership in medicine and society. for decades. I'm very humbled by this experience to be the second speaker. I would be considered more of an admirer of Dr. Vinik than anything else. So I hope to convey my admiration, continued admiration for his legacy, and to thank the Vinik family for supporting Arthur's legacy and continuing his influence on future generations of physicians and clinical researchers. I first met Arthur about almost 40 years ago. If I can share a slide. He was very dashing at the time. He came to give us a seminar at the Joslin Diabetes Center in '86 on multiple endocrine neoplasia. And I was in the audience as a fellow from Canada. And I was saying, who is this like dashing, very modelly dressed scientist that's talking about multiple endocrine neoplasia? In those days, we used to call them epidomas, but amazingly dressed. And I didn't know him at the pipe at the time, but as you can see, he certainly had the character of a Cary Grant. Most of us are wondering what he was actually doing in science rather than perhaps in Hollywood. But such is the dice that God throws us. So Arthur is destined to be a great scientist, as well as a dashing figure as well. Even more dashing, Etta shared with me this slide of him. He loved water sports. And here is water gliding, I guess. But what I was most impressed by the slide is that not only that he's doing it, but the fact that he's actually smoking a pipe while he is wind sailing or kite sailing. Amazing. Then I learned this new. Every year, or every time we talk about Arthur, some new revelation comes. And he was an amazing furniture maker. And these are examples of furniture that he himself had made and designed. Again, a testament to his broad spectrum of genius. So my task in the next few minutes, 30 minutes or so, is to talk about the origins and the future of incretin-based therapies, and to make it relevant in some way to what Arthur's mindset was and what his original thoughts were regarding endocrinology. I have no disclosures to disclose, and acknowledgement that some of the photos that you see are courtesy of Etta Vinik and Elias Siraj. Objectives are there for you to look at quickly. I will briefly describe Arthur's early work with the gut as an endocrine organ, differentiate incretins and their metabolic effects, recognize the pleiotropic effects of GLP-1 receptor agonists, and discuss the potential future of incretin-based therapies. So in preparation for this seminar, I looked through the older literature and tried to find some of his older publications. And here's a quote from his review, I think maybe while he was still in South Africa. In conclusion, I quote Professor Bank: "Endocrinology, which was born with the flourish in the gastrointestinal tract, the discovery of the first hormone, secretin, has returned to roost, and the place of the gastrointestinal endocrinologist is assured." So many, many decades ago, Arthur already conjectured that this future for what I would call gut endocrinology as a main player in the role of common endocrine disorders. So from secretin went to glucagon, gastrin, glucagon-like peptides, cholecystokinin, gastric inhibitory peptide. These have all been described in subsequent decades. And if you look at the origin and understanding of the incretin concept, here's the history of that originally from Minkowski, who conjectured about the beta cells in the pancreas, Bayliss and Starling, discovery of secretin, and then Starling, Labar, who came up with that nomenclature of the incretin concept, and through the decades so when I was about to launch sitagliptin, the first DPP4 inhibitor in the US, inhibitor that of the enzyme that degrades GLP-1 and GIP, Arthur called me up. And because at the time, Merck was talking about this as a brand new field, incretin science, etc. And Arthur called me directly at Merck and essentially lectured me, saying that this is an old concept. This has been around for many years. You need to really look at the older literature. And he, in fact, sent me reprints of his own papers as well as those by Kurzfeld. And so I'm indebted to him for giving me that a broader acceptance of the field, that this was not necessarily brand new in the 80s and 90s, but was much there beforehand. And here's a list of all of the hormones that have been listed now that are also been known to be gut hormones. Now, let me take you to Michigan, because Arthur spent some time in Michigan. And Arthur liked water. And for those of you in the audience that are from Florida and think that Florida has the longest shoreline, in fact, Michigan, in fact, has I believe, the longest shoreline of any state, other than maybe Alaska, but of the 49 landlocked states. And Michigan has an important place to play in the role of incretins. Here's a quote from Sir William Osler, 1902, who talks about the lovely Lake Michigan, lovely June day in 1822, to what were then far off northern wilds, to the island of the Michilimackinac, where the waters of Lake Michigan and Lake Huron unite, and where stands Fort Mackinac. Rich in the memories of Indian and Voyager, one of the 4 important posts in the upper lakes in the days when the Rose and the Fleur-de-Lis, the British and the French, strove for the mastery of the Western world. Now, it's not just to talk about the lake, but what was happening at Mackinac Island, Fort Mackinac, actually. So there was a famous physician, army physician, William Beaumont. He wasn't famous at the time. And he came across this patient, a French-Canadian, a Quebecer, Alexis Saint-Martin, who suffered a gunshot wound to his thorax and abdomen. And he was left with this is a wood cutting of the left chest and the left axilla there. And he recovered from the gunshot wound, but he was left with a permanent gastric fistula. And this led to essentially constant secretion of gastric juices. And Dr. Beaumont, his claim to fame, he conducted 200 experiments that we know of the principles of digestion, how it reacted to protein, meat, carbohydrate, fat, the nature of the juices, the fact that hydrochloric acid was in gastric acid at the time, the active ingredient. And also realized that showing Alexis samples of food led to gastric secretions. So the concept of incretins, which basically was even the concept of mentally preparing for food and the vision of food, stimulating some sort of secretions in the gastrointestinal tract, was already laid out here. Now, mind you, we're able to talk about them, but today's age, these probably would have to have IRB approval, etc. And then this famous paper from Diabetologia in 1979, Kurzfeld actually reintroduced the incretin concept from the 1930s, again, showing that the GI tract secreted hormones through the GI tract and affecting the beta cells, you can see in the cartoon on the left, and the islet, causing insulin secretion. So this concept was not born in the 2000s, certainly. So the gut is an endocrine organ. We know that the bowel cells, small intestine in particular, secrete GLP-1 and GIP. GIP, when I was a medical student, was known as gastric inhibitory peptide because it was thought to inhibit gastrin. And nowadays, the abbreviation is the same, but it's known as the glucose-sensitive insulin stimulatory peptide. So it's a GIP still, and GLP-1, glucagon-like peptide 1. And these basically are secreted by the gut in response to food or the sight of food, travel through the endocrine system, through the circulation, and affecting the distal organs like the beta cells and alpha cells in the pancreas and maybe other organs as well. GLP-1 action is summarized here in the cartoon, interacting with the GLP-1 receptor on the beta cell. There are a number of other receptors as well, but what's interesting about the GLP-1 is that it causes insulin secretion in response to changes in glucose. So if the glucose levels are low, it does not cause insulin secretion. So it's very much a glucose-sensitive insulin secretion process. And this is the main reason that GLP-1 has become to the forefront for the use in diabetes. Some GLP-1 receptor agonists have been used now in for obesity and to prevent diabetes. Here's a paper using tirzepatide molecule that stimulates both GLP-1 and GIP receptors. And you can see the effect on the glucose levels as well as the incidence of prediabetes and lower panel having a beneficial effect. Right now, tirzepatide is not officially approved for prediabetes, but this are data that will support that claim in the near future. And other aspects of diabetes, not only, but for heart failure. You're all familiar now that these medications not only have a benefit on the endocrine system, but also have a benefit on the cardiovascular system. And here's a paper looking at semaglutide, again showing benefits of for heart failure and CKD as well compared to placebo. And more recently, MASH. So you have GLP-1 analog having potential benefits on metabolically associated steatic hepatitis and MAFLD, etc. And there's a growing research in this area where a number of agents are being studied. This is a study looking at tirzepatide, but semaglutide has many papers as well, studies. And I think you'll see this coming to the forefront in the very near future of an indication for MAFLD and MASH for the use of GLP-1 analogs. And more recently, even more exciting, is this concept of so-called reset with semaglutide. So you have a technique called electroporation therapy. And what this does is essentially it induces cellular apoptosis and subsequent reepithelialization in the duodenum. And at the same time, these patients are being exposed and treated with semaglutide. And this is I'm reporting the first in human study here, which showed that in these adults that underwent this procedure, that it demonstrated a success rate of 100%. No device-related severe adverse events, no severe hypoglycemic events were observed. And at the 12-month follow-up, amazingly, 12 patients, so 86% of the patients remained off exogenous insulin therapy. And again, the electroporation therapy itself is effective, but the combination with the incretin-based therapy was even more effective. Now, the durability of GLP-1 analog effects, some may question, well, are these drugs going to be long-lasting, or is it a cure? And right now, the data from the beta cell studies suggests that the beneficial effect is there while the GLP-1 analog is on board. But upon withdrawal of the medication, the beta cell benefits tend to disappear. In other words, the insulin secretion that's there from the beta cells tends to wane if the GLP-1 analogs are removed from the patient. Individuals with weight loss due to GLP-1 analogs tend to regain their weight upon discontinuing their medication. On the other hand, we just recently heard from Dan Drucker, one of the key scientists in the GLP-1 field, that there may be about 25–30% of patients that even after withdrawal from the GLP-1 treatment, they are able to maintain their weight loss. So there may be a difference between so-called responders and non-responders with regard to maintenance of weight loss. So this remains to be seen what kind of factors or variables that might describe those particular individuals. The weight loss itself tends to plateau by 12 to 18 months. And one needs to look at, from a pharmacoeconomic data analysis, what are the cost benefits of loss of weight, obesity, having effects on other disorders related to obesity, such as sleep apnea, cardiac disease, a number of other disorders, polycystic ovary syndrome, etc., might be improved. Quality of life would be affected as well by the benefit of weight loss. One of the key things, though, is not to give the medication only, but critical to add lifestyle measures. So the involvement of a nutritionist and other exercise measures to enhance the weight loss would be extremely important. So the summary of the incretin actions on different target tissues, we don't have the time today to go into all of the science behind the receptors, etc. But keep in mind that in order for a hormone to be effective on a particular organ, the receptor has to be there in that organ. The hormone itself can't just willy-nilly go to an organ, circulate in the blood, and have an effect. It has to work through a receptor, second messenger pathway, and an effector pathway to have an effect on the cell and adjacent cells. So right now, incretins are deemed to have these different effects. So the pancreas, which is looking at 4 o'clock, increase in insulin secretion, reduction in glucagon secretion, for example. Then if you look at muscle at 6 o'clock, increase in muscles, insulin sensitivity, liver, decreased glucose production, potentially other liver effects that are maybe associated with fatty liver. And then the heart, cardiovascular effects. There's good data now, not only conjecture, but good interventional data that GLP-1 analogs seem to protect a patient from the ramifications of both ischemic heart disease as well as heart failure. And in the brain, there appear to be effects on neuroprotection and reduction in appetite. Now, early on, when we were launching sitagliptin in 2006, I would hear reports from across the country, doctors reporting, at the time, it would not necessarily be an adverse event, but they'd be reporting anecdotes that their patient suddenly seemed to have an improved memory. And we were hearing the same stories about when exenatide, which was made by a competitor, was also being used in type 2 diabetes, that exenatide seemed to improve some people's short-term memory. And you may not realize it, but lo and behold, some of the business-minded people have already patented all of the potential indications that one might think of where GLP-1 receptor agonists might be useful. So somebody has already probably copyrighted or patented potential use of GLP-1 analogs for Alzheimer's and et cetera. But we'll still talk about it scientifically. So we know that signaling from the brain affects energy expenditure. So the effect on the appetite and the weight loss that GLP-1 analogs have. Initially, we thought it was due to nausea, vomiting, delayed gastric emptying, GI effects. But we came to realize that these GLP-1 analogs do cross the blood-brain barrier and have effects on the brain. And the brain itself has an effect through the autonomic nervous system, which again was a godchild of Arthur Vinik. He was just an aficionado for autonomic neuropathy and the autonomic nervous system. So the brain itself affects the liver, the stomach, the beta cell function, all sorts of end organs, maybe even adipose tissue. And so GLP-1 analogs may be having a secondary effect on metabolism through its effects on the brain. So again, to reiterate all of the different aspects that GLP-1 analogs, these would support the fact that we are having pleiotropic effects in our patients. So not only indication for type 2 diabetes, but now we have an indication for sleep apnea, potentially. I think tirzepatide has just recently been approved. CKD, heart failure, the benefits of that has been clearly demonstrated. So pleiotropic effects, when a particular medication first comes out, there's a debate. We as physicians are quite excited about seeing pleiotropic effect. Some of them could be good, but the pharmaceutical companies are worried about pleiotropic effects, and some of the effects could be bad. What they prefer to see is a very single-focused their medication, single effect, and not to be concerned about these pleiotropic effects. But we now know that even oral agents, oral drugs, tend to have pleiotropic effects. That in fact, even though they may affect one single mechanism, if you actually study the genetic effects and the metabolomic effects of oral drugs, they may have 70, 80, 100 or more different effects on different metabolic pathways and in our bodies. So specificity versus non-specificity continues to be a continuous debate. However, we know that GLP-1 analogs do have these effects, and over the years these have been affected. If you look at the very around 1 o'clock, 2 o'clock, increased fatty acid synthesis, thermogenesis, lipolysis, heart, cardiovascular contraction, frequency, cardiac output, gluconeogenesis in the liver, ketogenesis, glycogenolysis, glucose uptake, bone formation. GIP has been conjectured to play a role in bone formation. We already talked about gastric emptying, GI motility, beta cell mass, insulin and glucagon release, memory, food intake, and appetite. So it's no wonder how these drugs may be used for different indications in our clinical venue. So sleep apnea. This is a SURMOUNT study looking at tirzepatide and showed a clear benefit of tirzepatide in patients requiring less CPAP and less apneic episodes. And I believe it has been approved now for sleep apnea. Weight management and NAFLD. As you can see, GLP-1 receptor agonists are preferred agent in those more moderate to severe stages of NAFLD or MAFLD, which have increased fibrosis risk. And here you can see the effects again on a number of different aspects of physiology. And let's talk about Alzheimer's. Alzheimer's, for the general audience, there's a growing literature about insulin resistance in the brain. So who knows, Alzheimer's might also become an endocrine disorder in the near future. There are definitely scientific evidence of low glucose metabolism or energetics in the brain in individuals that have Alzheimer's. There are definitely markers of neuroinflammation, oxidative stress, advanced glycosylation end products, and mitochondrial dysfunction in the tissues of people with Alzheimer's. and the accumulation of beta amyloid, tau protein, and amylin in Alzheimer's as well. Obviously, in people with diabetes, have a higher incidence of cognitive impairment. Hypoglycemia, we know, is a major risk factor for cognitive dysfunction. And then we also have higher levels of neuroinflammation and the same risk factors that are seen in Alzheimer's. So interestingly, in terms of pathogenesis, we're seeing similarities between diabetes as well as what's happening in our patients with Alzheimer's. And there is certainly preclinical data that GLP-1 receptor agonists seem to have beneficial effects on the brain and seem to counter many of the pathophysiologies that have been expressed as being abnormal in individuals with Alzheimer's. There is some data that suggests that these metabolic changes have been able to be affected positively with GLP-1 receptor agonists, but we are still waiting to see hard outcome data. So right now we have anecdotal data, we have metabolic data, but we're waiting for the actual hard outcome data of the impact of these incretin-based therapies on memory and hard outcomes. Parkinson's disease. Here's a study with lixisenatide compared to placebo, looking at a Parkinson's scoring system, where you can see in the placebo, symptoms worsened, and those individuals on lixisenatide, symptoms seemed to plateau or were stable during the study period. Again, very early data, but there's growing interest in potentially using these agents for patients with Parkinson's. And there are definitely anecdotal data and reports, small reports of use in anxiety, depression, mood stability, emotional and stress-related eating. So the GLP-1 receptor stimulation, very simply, seems to affect the dopamine pathway as well. And the dopamine pathway has been very clearly implicated in nicotine addiction or nicotine use disorder, stimulant use disorder, opioid use disorder, or cocaine use disorder. And so if GLP-1 receptor agonists modify or modulate the dopamine receptor pathway in the brain and in the autonomic nervous system, and we know it's having effects in our patients with diabetes with respect to appetite, could it be having beneficial effects in these particular substance use disorders with other substances other than food? And sure enough, there have been some clinical trials using semaglutide for primarily, but more recently you've seen tirzepatide. And as you can see, there's some older studies with some of the older GLP-1 receptor agonists as well, liraglutide, exenatide, and dulaglutide still being used, of course, also has some positive data. So the summary here is that let's focus on the left side of the graph, that you have GLP-1 receptor agonists showing some promise in alcohol use disorder, which is obviously highly prevalent in our society. You can see it reduces alcohol intake, reduces the scores for in alcohol use disorder patients. The desire to consume alcohol is reduced, and alcohol-related posts. In other words, the thinking about alcohol is also reduced. So all of this suggests that there's a positive benefit. And interestingly, this is the same thing that's reported in our patients that undergo bariatric surgery. When I talk to after the surgery, patients come and they say, they've lost weight. And I ask them, well, how do you feel? The first thing they say is that, doctor, I didn't want to tell you this before, but I used to think about food all the time. When I was at my desk at work, between breakfast and lunch, between lunch and dinner. But after the bariatric surgery, I no longer think about food. And something similar is happening, I think, with GLP-1 receptor agonists as well. So the pleiotropic effects, they're having effects on vasodilation, anti-inflammatory, beta cell protection, antioxidative stress, antifibrotic effects perhaps as well, which you're thinking about in terms of MAFLD and MASH. So there's some pathophysiology now and biochemistry backing up the clinical effects that we're seeing in our patients and backing up our clinical experience. So we've already gone through from 2005 to 2006 when the incretins were first introduced to the US market. And in the last 20 years or so, now we're moving to tirzepatide at the very top right-hand corner. And you're seeing further research on further combination therapies, looking at GLP-1, actually combining with so-called a triple agonist, amylin to leptin and glucagon. A number of other gut peptides are being connected to GLP-1, and you'll see more trials in the next few years exploring all sorts of combinations and potentially coming up with even better therapies. And GLP-1 here again, fusion of GLP-1 with other gut hormones. The PDF of this presentation, Dr. Siraj and Dr. Lieb, they have a copy and we'll certainly be able to share it with you if you like after the presentation. So the unifying theory, to bring it back to Professor Vinik, Arthur had his, I would say, two key interests. One was autonomic nervous system, and the other was his gut as an endocrine organ. And we were talking to the Viniks and Siraj and Lieb earlier about Jesse Roth at the NIH, et cetera. But I think Arthur certainly would be a proponent of this, I would say, unifying theory for the neuroendocrine system. And rather than to be a splitter, I would propose that we engage the neurologists as colleagues, true colleagues, and also as endocrinologists. Because many of these neuroendocrine hormones, gut hormones, are actually being secreted by the neuronal system, by the brain. And it just so happens that the neuronal system is hampered because the neuronal system is built like a traditional landline system. Whereas the endocrine system, including the GI system, is built like a cellular network. We make hormones and we send them out through broadband or whatever you want to call it to act on distant organs, distant cells. But the signals are the same. So if only a neuron, for example, yes, the vagus nerve is probably one of the longer nerves, can travel from the brain to the gut and have an effect. But fundamentally, the neuroendocrine system are closely related and probably are children of the same parent. And we are just working and operating differently. But if you look at the physiology and the location, and the fact that you describe a hormone in the gut, and it's there in the brain, etc., it's just incredibly how the engineering behind how human body is constructed. So to our audience or attendees, the train has left the station. It's no longer a conjecture about our GLP-1 analogs or incretins are here to stay. So the concept that Arthur proposed back in the early 70s, resurrected in terms of how the gut as an endocrine organ has arrived. And we are now leveraging the benefits of that physiology. And we just need to get on board and obviously continue to study for the benefits and adverse events, of course, but we're looking forward to an exciting time in the next few years for not only endocrinology, but all of clinical medicine. In terms of Professor Vinik, in closing, let me just say that for those of you that are interested in a more detailed description of Arthur's journey, I would point to Dr. Lieb's, Parson, Castellini, and Siraj's article in Endocrine Practice published in 2023. So now, as we're about, I believe, just a little more than 2 weeks away from celebrating the second year of Arthur's passing, want to again recognize Arthur's accomplishments, not only in science, but in life in general. As you can see here, the picture tells you that he was an athlete. He was a born athlete, not only a runner, but a footballer. And even to do water sports, you have to have incredibly strong legs. And Arthur's physique is just amazing. Of course, the physique was not only used for sports, but here's his wonderful family, 3 sons. Look like they're definitely from a James Bond movie. I guess Howard, Brian, and Stephen, and Etta. And he's definitely a family man. So beyond the science of gut hormones, multiple endocrine neoplasia, INGAP, diabetic neuropathy, cardiac autonomic neuropathy, where I collaborated for several years with Arthur when I was at the Cleveland Clinic. So there are a number of fields that I'm sure in the years to come you'll have speakers to talk about different aspects of Arthur's interests and contributions. But also, he was a track athlete, star, soccer athlete, wine enthusiast, and wine, I guess there's a name for a enologist. Yes, I think windsurfing, tennis, of course, furniture making, I learned just in the last year. Dancing, he's an incredible, and Etta too, I think, are incredible dancers. And I saw him at the one of the ACE national meetings where he was just demonstrating his dancing skills on the floor. And with that, I'll leave you with a quote that if I have seen further, it is by standing on the shoulders of giants. And I will posit that Arthur was a true giant. And I want to thank you. I want to thank the Vinik family, Dr. Siraj and Leeb again for the kind invitation. Thank you for listening, and look forward to any questions or comments that you might have. Thank you again. Thank you.
Thank you, Dr. Reddy. That was great. So I will open the podium for questions and answers. Do we have someone monitoring the chat as well for questions? Okay. Questions? Yeah. Okay, let me, yeah, go ahead. Yes. Yeah, and then speak.
Well, thank you so much, Dr. Reddy. That was very enlightening. And thank you so much for being here, even though you weren't able to be physically. So, my practice of medicine in Florida is inspired by my dad and people like yourself who do all of the groundwork and the research and come out with the clinical trials and hand it down to us and tell us, how best to practice medicine. I have a lot of obese patients, a lot of diabetics in South Florida, and we have a lot of choices now. And there's 15 classes of diabetic medications now, according to Dad's previous lecture. Do you use GLP-1s as first line if cost wasn't an issue at this point? Because we used to use metformin, and now we have SGLT2s and GLP-1 receptor agonists. Where do you suggest we start?
Right. No, that's a great question. I come from Cleveland Clinic, of course, where the land of Steve Nissen. He's the one that most endocrinologists have some issue with. But he raised a quick question. We would talk about metformin, sulfonylureas, and we were very reluctant to come up with outcome studies, cardiovascular outcome studies. But over the years, I think Steve has forced the issue. And in the last 15 years, there have been outcome studies looking at cardiovascular and renal outcomes. So we now have the data, so to speak, to go to the regulators and the payers to say that not only do these drugs improve glucose control, but they have hard benefits on outcomes like cardiovascular disease, heart failure, ischemic heart disease, chronic kidney disease evolution. So I think you're right. As the price drops. And these become more acceptable even in terms of perhaps even monthly injections, or oral therapies, of course, are being tested as well. But I think based on the outcome data, they will move to frontline. And already we're seeing some progression. The ACE guidelines, for example, an algorithm clearly dropped what we'd call hypoglycemic drugs, like sulfonylureas, et cetera, to more bottom. Metformin is controversial now in terms of, to be first line in some cases. And TZDs have their issues, of course, as well. So if you look at right now, I think the on the rise would be GLP-1 receptor agonists and SGLT2 inhibitors, which also seem to be having pleiotropic effects, not only affecting their particular sodium glucose transporter, but having effects on the autonomic nervous system, cardiovascular system, blood pressure, etc.
Thank you, Dr. Reddy, for a fantastic presentation. So given that the GLPs have pleiotropic effects, that leads to a number of different clinicians being involved in using them and caring for a single individual. What sorts of things do we need to be thinking about as clinicians and nurses and physicians as we move forward with working together to ensure that we're all using the drug safely and thinking about adverse effects and that sort of thing?
I think that's a great question, Dr. Lieb. I think when these medications become ubiquitous, there's a danger. And there's a reason why right now, in the last even 5 years, the safety record has actually been very good. There have not been that many cases of those sporadic, 1 in a million, gut paralysis, for example, that I'm sure you've heard of, where someone's gut is entirely, basically becomes a static pipe. And the reason is that we're very watchful, very careful, and we're watching our patients carefully. I think when they become ubiquitous, we tend to become used to the idea that, every other patient is on this in garden variety, so that we tend to not pay attention to potential side effects. And that's when the side effects in clinical trials, Brian was asking about clinical trials. Clinical trials involve maybe, let's say, 20,000 patients. So if a side effect happens in 1 in 30,000, then we might not pick it up in that clinical trial. It's only when the drug becomes clinically used in the public domain, we might pick it up. So when 1 million people or 10 million people start using a particular agent, you'll pick up those 1 in a million, 1 in 10 million adverse events. The other thing to do, of course, think about is when we embark on a medication, should we do a baseline catalog? Does this patient have a substance use problem? Does he have other medical issues that could benefit? Very simply, our diabetes patients, you have fatty liver, sleep apnea, and diabetes, already a triple combo right there that potentially could be a triple indication. Now, that might make our job easier, I think, with the payers, because they have less reason to refuse the medication. But I think those are 2 issues that come to mind. I haven't thought about it deeply yet, but certainly be glad to hear if you have any thoughts, or if anyone else in the audience may have thoughts.
Dr. Carboni.
Thank you very much for the presentation. I have a question related to the use of GLP-1 incretin-mimetic drugs in real world. In clinical trials, often, even in the control group, we see improvements in weight loss and hemoglobin A1C. Patients are, they're part of a very well organized team. And so the side effects tends to be relatively small in percentage of patients. Real world data seems to suggest that a large proportion of patients end up not tolerating these agents as well as we would like. And so they end up stopping the drug. Is there a way for sort of identifying those patients early, and what can we do when the side effects, particularly GI side effects, occur? And whether, the other question is, do you possibly try a different GLP-1 receptor agonist, or you just decide to change class when those patients develop those side effects? Thank you.
Right. So I think that's an important comment. I think that we're all victims of our experience, so that if we happen to see highly selected patients and highly motivated patients, they tend to do better. They probably minimize the side effects. So I see patients that are really, I won't say desperate, but they're highly motivated to wanting to use these agents. So they do very well. And I don't see, obviously, patients that are using it for cosmetic purposes, et cetera. And I think the other patients, yes, the more we use it, you will see those side effects. Obviously, starting at a low dose, I'm not contained or constrained by the FDA formula in that if the label says you must use once a week, well, I'm open to using it once every 10 days, every 12 days. Who says that? So I'm looking at other combinations. I'm certainly trying a different medication in the same class would make sense because they're not identical compounds. So dulaglutide, semaglutide, tirzepatide are quite different. And then, of course, some of your insurers are going to insist that you try liraglutide or something older as well as a prelude to looking at the newer medications. I haven't tried actually minimizing the side effects. Like I don't give agents to stop their nausea or things like that. Some of the side effects include things like things you might want to try would be just they don't like certain foods, meat, fatty foods. You may want to change their menu choice, but obviously it's your clinical acumen that's important here. I know we're running out of time, but
maybe one brief last question. When you were at Merck 15 years ago, DPP-4s were huge. And thanks to your role, they did very well. Sitagliptin for sure did very well. Now GLP-1s are on the rise and becoming blockbuster. Do we still need DPP-4s?
Yes. So I think because what are the benefits of DPP-4 inhibitors? So they are relatively safe. They have minimal side effects. They do have similar efficacy if you use it at the same stage of diabetes, believe it or not, to metformin or some of the other oral agents in terms of glucose lowering. I think when individuals have diabetes for a longer period, have a higher A1Cs, they may not respond as well. But again, the combination of a DPP-4 inhibitor with an SGLT2 inhibitor and a TZD, all generic, would be a tremendous power play, I think, in terms of safe, well-tolerated, and no chance of hypoglycemia. And if you use a very small dose of TZD with the SGLT2 inhibitor and the DPP-4 inhibitor, you actually have a good combination therapy that would be very effective.
Thank you, Dr. Reddy, for the great presentation. And thank you, everyone, for being here. And thank you for the Vinik and for everyone. Thank you.